What if the pill your doctor prescribed to help you sleep, calm your nerves, or control your bladder is quietly and systematically destroying your brain? This is not a scare tactic. This is not a conspiracy theory. This is documented science. And if you or anyone you love is over the age of 60, what you are about to hear in the next 20 minutes could genuinely change or even save a life. Millions of older adults are taking medications every single day that have been scientifically linked to a significantly increased risk of dementia. And the terrifying truth is that most of them have absolutely no idea. So stay with me, because we are going through all 9 of these medications one by one, explaining exactly what they do to your aging brain, why the risk is so much higher after 60, and most importantly, what you can do about it. Before we get into the list, you need to understand one critical piece of biology, and it will make everything else we discuss today make perfect sense. As we age, our brains change in very specific ways. The blood-brain barrier, which is essentially the protective filter that stops harmful substances from entering your brain tissue, becomes more permeable and less effective after the age of 60. At the same time, the number of neurons we have begins to decline, and our brain's ability to produce and manage key chemicals like acetylcholine, which is absolutely essential for memory and learning, starts to drop. Now, here is why this matters so much in the context of medication. A drug that a 50-year-old might take and clear from their system relatively quickly can linger far longer in the body of a 65 or 70-year-old. Their kidneys process things more slowly, their liver enzymes are less active, and their brain is simply more vulnerable. What might be a minor inconvenience for a younger person can become a neurological catastrophe for someone in their senior years. With that foundation in place, let us start with the first medication on our list. The first category is sleeping pills, specifically the class of drugs known as benzodiazepines and the related group called Z-drugs. These include well-known medications like Ambien, Lunesta, Sonata, Valium, Ativan, and Xanax, among others. These drugs work by enhancing the effect of a neurotransmitter called GABA in the brain, which creates a sedating, calming effect. Sounds helpful, right? The problem is that with prolonged use, and the research defines prolonged as anything beyond 2 to 4 weeks, these drugs begin to interfere with the brain's natural architecture of sleep. They suppress the deep restorative stages of sleep that the brain desperately needs to flush out toxic waste products, including a protein called amyloid beta, which is one of the primary hallmarks of Alzheimer's disease. A landmark study published in the British Medical Journal found that long-term benzodiazepine users had a 51% higher risk of developing Alzheimer's disease compared to non-users. The longer the use, the higher the risk. And yet millions of older adults are on these medications for years, sometimes decades, with their doctors continuing to refill the prescription without a second thought. Moving on to our second medication, we need to talk about antihistamines, and specifically the older first-generation type. If you have ever reached for a Benadryl whose active ingredient is diphenhydramine to help with allergies, a cold, or even just to fall asleep at night, pay very close attention. Diphenhydramine is what researchers call strongly anticholinergic, which means it directly blocks the action of acetylcholine, the brain chemical that is most critical for memory and cognitive function. This is not a minor side effect. This is the primary mechanism of the drug, and in older adults it is devastating. The brain of a 60-plus-year-old is already producing less acetylcholine than it used to. Introducing a drug that blocks what little remains is like starting a fire in a house that is already short on firefighters. Multiple studies, including a major one from the University of Washington, have found that people who regularly used anticholinergic drugs like diphenhydramine had a substantially increased risk of developing dementia. And these are available over the counter. You can buy them at any grocery store, which gives many people the false impression that they must be completely safe for regular use. They are not, particularly not for older adults. The third medication is one that surprises people the most: bladder medications. Drugs prescribed for overactive bladder, a very common condition in older adults, include medications like oxybutynin, tolterodine, solifenacin, and darafenacin, sold under brand names like Detrol, Vesicar, and Ditropin. Here is the problem: these drugs are also strongly anticholinergic. They work by blocking the nerve signals that cause the bladder to contract involuntarily, which is effective for the bladder. But the same blocking effect happens throughout the entire nervous system, including the brain. A major study from the Journal of the American Medical Association found that older adults taking these bladder medications were 54% more likely to develop dementia. In fact, oxybutynin specifically is one of the drugs most frequently flagged by the American Geriatric Society as a medication to avoid in older adults. And yet it is one of the most commonly prescribed drugs in that same age group. If you are taking something for bladder control and you are over 60, please talk to your doctor about whether safer, non-anticholinergic alternatives exist for your situation. The fourth medication category is antidepressants, and here we need to be careful and nuanced because the relationship is complicated. Not all antidepressants carry the same risk. The category of concern here is primarily the older tricyclic antidepressants, drugs like amitriptyline, nortriptyline, imipramine, and doxepin. These medications are sometimes prescribed not just for depression, but also for chronic pain, nerve pain, migraines, and even sleep problems in older adults. The trouble is that these drugs are also significantly anticholinergic. They block acetylcholine, they can increase confusion, impair memory, and with long-term use they have been associated with an elevated risk of dementia. Even some of the more commonly used antidepressants, like paroxetine, sold as Paxil, carry meaningful anticholinergic burden. If an older adult needs treatment for depression, and depression itself, by the way, is a known risk factor for dementia, the goal should be to choose a medication with the lowest possible anticholinergic impact, not the highest. Our fifth category is something that many older adults depend on for daily functioning: medications for an overactive or irregular heart, specifically some antiarrhythmic drugs. One in particular, called digoxin, has been used for decades to treat heart failure and atrial fibrillation. It has an extremely narrow therapeutic window, which means the difference between a beneficial dose and a toxic dose is very small. In older adults, because the kidneys process it more slowly, digoxin can accumulate to toxic levels in the blood, leading to confusion, visual disturbances, and cognitive impairment that can look very much like dementia. Beyond digoxin, some other heart medications can also affect brain blood flow and pressure in ways that, over time, contribute to vascular dementia, the type caused by reduced blood supply to the brain. If you are on medication for a heart rhythm condition, it is worth having a conversation with your cardiologist specifically about cognitive side effects, particularly if you have noticed any changes in your memory or clarity of thinking. The sixth medication is one that shocks people even more than the antihistamines, proton pump inhibitors or PPIs. These are the drugs commonly taken for acid reflux and heartburn medications like omeprazole, esomeprazole, lansoprazole, pantoprazole, sold as Prilosec, Nexium, Prevacid, and Protonix. They are among the most widely prescribed and most widely purchased over-the-counter medications in the world. Multiple large observational studies, including research published in JAMA Neurology, have found an association between long-term PPI use and increased risk of dementia. The proposed mechanism is that PPIs may reduce levels of vitamin B12 in the body by inhibiting stomach acid, which is needed to absorb B12 from food. B12 deficiency is a well-known contributor to cognitive decline and memory problems. PPIs may also interfere with the clearance of amyloid beta from the brain. The key word here is long-term. Using a PPI occasionally for a week or two is very different from taking it every single day for years, which is what tens of millions of people are doing, many of them without even mentioning it to their doctor because they bought it over the counter. The seventh medication on our list is muscle relaxants. Drugs like cyclobenzaprine, carisoprodol, and methocarbamol are frequently prescribed for back pain, muscle spasms, and musculoskeletal injuries. Older adults are particularly likely to be prescribed these after a fall or injury, the exact time when their brain is already under stress. The problem with muscle relaxants in older adults is multifold. Many of them are anticholinergic. They cause sedation and dizziness. They can produce a state of confusion and mental fog that, in a person with an already vulnerable brain, can tip over into something that looks and feels like a much more serious cognitive condition. Short-term use of muscle relaxants is generally considered higher risk than benefit in adults over 65, and the American Geriatric Society's Beers criteria, a widely respected guide for prescribing in older adults, specifically recommends avoiding most of these medications in this population, Yet they are still being prescribed, and patients are still filling those prescriptions without knowing what the research says. The eighth medication is one that we associate with psychiatry and serious mental illness, but is increasingly being used in older adults for agitation, anxiety, or even as a sleep aid, antipsychotics. Medications like quetiapine, sold as Seroquel, as well as risperidone, olanzapine, and haloperidol, are being given to older adults for off-label purposes that would frankly shock many families if they understood what was happening. These drugs carry a black box warning, the most serious type of warning the FDA issues, specifically stating that they increase the risk of death in older adults with dementia. They also, in people who do not yet have dementia, carry significant risks of accelerating cognitive decline. They cause sedation, they interfere with balance and coordination, and their metabolic effects can indirectly harm the brain through changes in blood sugar and inflammation. If someone you love is in a memory care unit or a nursing facility, and is being given an antipsychotic, ask the clinical team to justify that prescription and explore non-pharmacological alternatives. The ninth and final medication is corticosteroids, which includes drugs like prednisone and dexamethasone, commonly prescribed for inflammatory conditions like arthritis, asthma, COPD, and autoimmune diseases. Short-term corticosteroid use is generally manageable. However, long-term use, and in older adults this very frequently becomes long-term, carries significant neurological consequences. Corticosteroids suppress the immune system broadly, and chronic use has been associated with shrinkage of the hippocampus, which is the part of the brain that is most critical for forming new memories, and is the area most severely damaged by Alzheimer's disease. Chronic corticosteroid use also promotes high blood sugar, blood vessel damage, and systemic inflammation when the drug is withdrawn, all of which are risk factors for vascular damage to the brain. Patients on long-term steroids should be monitored not just for bone density and blood sugar, but also for cognitive changes, and every effort should be made to reduce the dose to the lowest effective level. Now that we have walked through all 9 of these medication categories, there are several things you need to hear about what to do with this information. The first and most important thing is this: do not stop taking any prescription medication without speaking to your doctor. Some of these drugs are being taken for conditions that could be life-threatening if left untreated. The goal is not to throw away your medications. The goal is to have an informed, specific conversation with your healthcare provider about your individual risk. Ask your doctor directly, are any of the medications I am currently taking associated with cognitive decline or dementia risk? Is there a safer alternative that would treat the same condition with less neurological impact? Is the dose I am on the lowest effective dose? Could I reduce or taper off any of these if I made certain lifestyle changes? These are not confrontational questions. They are exactly the kind of questions your doctor should welcome from an engaged, informed patient. The second thing to take away from today is the concept of deprescribing, which is a growing movement in geriatric medicine focused specifically on identifying medications in older adults that are doing more harm than good and safely reducing or eliminating them. Ask your doctor if they are familiar with the Beers criteria or the stop and start criteria. These are clinical tools specifically designed to evaluate medication safety in older adults, and not every physician uses them routinely unless the patient asks. The third thing is to get a complete medication review. Many older adults are seeing 4, 5, or 6 different specialists, each of whom may be prescribing something without a full picture of everything else the patient is already taking. A pharmacist, particularly a clinical pharmacist who specializes in older adult care, can perform what is called a comprehensive medication review and flag potentially dangerous interactions or duplications that none of the individual prescribers may have noticed. To bring everything together, the 9 medications we covered today that carry documented risk for dementia and cognitive decline in adults over 60 are sleeping pills and benzodiazepines, first-generation antihistamines like Benadryl, overactive bladder medications, certain antidepressants, particularly the tricyclic class, some heart medications including digoxin, proton pump inhibitors used long-term, muscle relaxants, antipsychotics used off-label, and long-term corticosteroids. The underlying themes connecting most of these are their anticholinergic properties, their disruption of sleep architecture, their interference with brain chemistry, and the simple fact that aging bodies process these drugs more slowly and aging brains are more vulnerable to their effects. Knowledge is your most powerful tool here. Share this information with the people you love. Print it out, bring it to a doctor's appointment, have the conversation. Because the best outcome is the one where you prevent a problem before it begins. If you found this information valuable and you believe it could help someone you know, please take 3 seconds right now to hit that like button and subscribe to this channel. It genuinely helps more people find this kind of content when they need it most. And drop a comment below and tell me, were any of these medications on your own list, or are there other health topics you want me to cover next? I read every single comment, and your suggestions directly shape what we talk about here. Thank you so much for watching, and I will see you in the next one.